Okay, so today on Road to 250, I'm going to talk about fluid distribution physiology. So I'll touch on some of the concepts that relate to those concepts. Okay, so to start off with, so general concept, distribution of fluid within our body. As we know, 60% of our body mass is made up of water. And so, for example, if we were talking about an average man who's probably 70 kilograms, 60% of that would be liters. And then when we break down total body water, we have intracellular fluid, which would be 65% of the total body, or 28 liters of water. And then talking about extracellular fluid, this would be 35% of the total body water, third, which would be 14 liters. So the intracellular, as we know, is 2/3. Extracellular is 1/3. And then to break it down just a little bit more, extracellular fluid is made up of fluid and interstitial fluid. So to see this more in words, intracellular fluid, so intracellular inside the cell, is 2/3 of the total body water. Extracellular fluid is 1 total body water. And then within the extracellular fluid, we have the interstitial fluid, which is 3/4 of the extracellular fluid volume. And then the plasma volume makes up the other quarter cellular fluid. And then there's also a vascular compartment, or essentially plasma volume, which contains blood volume, which is plasma and cellular elements of blood. So red blood cells. So this slide here is continuation of what we normally will see in physiology in terms of distribution of fluids. And it becomes relevant when we start talking about the Darrow, Yannet diagrams in a little bit. But this is just our common, what we see in our physio books, with the 2/3 ICF, 1/3 ECF, and then that broken down into the interstitial fluid and the vascular volume that we just talked about. To further that, as I mentioned on the last slide, the vascular volume or the plasma volume is kind of the same idea there. But what I wanted to bring up in addition is this barrier. So the barrier between the intracellular fluid and the extracellular fluid is going to be our cell membrane. And the cell membrane is not a barrier for water, but it is for sodium. Hence why the next concept when we talk about osmosis or in general diffusion, it makes sense why the cell membrane is going to determine kind of what's going on within the body. And then the next barrier that's relevant here is the barrier between the plasma volume and the interstitial fluid. It's known as a capillary membrane. So remember, the vascular volume is like our blood, and then we have our interstitial fluid. So here, this barrier is going to be for large particles like proteins. And that becomes clinically correlated in regards to like edema. I'm not going to talk about that today, but that is why that is important. What is, I guess, fun fact / question, the most abundant protein in our body?
Albumin?
Yeah, for the most part, albumin, but something else I've learned also is collagen. But albumin within our body is the most common protein, but collagen in terms of our skin, since skin is also quite abundant. But anyway, fun fact. Okay, moving on. This is just another picture to kind of put things in perspective for us in terms of the body distribution. So fluid, 60%, the intracellular, extracellular, and then that further broken down into the interstitial and the plasma. So you guys can just use that as a reference. Okay, so the next concept I wanted to introduce is osmosis, as it's going to be important in my ultimate concept I'm discussing today. So osmosis is the distribution of fluid that's determined by the osmotic movement of water. Osmosis is the diffusion of water across a membrane, such as semi-permeable membrane or a selective permeable membrane. So a key word is the diffusion of water. Now, water diffuses from a region of high water concentration to a low, or it means to say to a region of lower water concentration. So the general rule, as we know, high to low, is going to be the way diffusion wants to work. So the concentration of water in a solution is going to be determined by the concentration of the solute. So if we have greater solute concentration, the water concentration is going to be low, essentially the greater the solute concentration, the lower the water concentration is going to be. So the ratio is greater number of particles means less water concentration, right? Because it's overly saturated by solute. And to put this further into perspective, I have a picture with the beaker and then a more clinical correlation. So in regards to the beaker, the compartments are separated by the red dashed line. So that's going to be representing a membrane. And so side B, as we can see, has greater concentration of the solutes, so the particles. And so it's then, therefore, going to have a lower concentration of water compared to side A. And so, as we know, so what would be the flow of water diffusion in the beaker?
From A to B.
Right, A to B. So in A, there's less particles, so more water available. The ratio is more water. And on side B, there's more particles, but less water distribution per particle. And so to equalize it, or to create equilibrium, the water is going to diffuse from high to low. So it's highest on side A. Water is highest on side A. So it's going to move to side B, where the water concentration is low. And then on the right-hand side picture, we're looking at a cell that's distinguished by the orange. And we're saying that glucose is the particle that we're looking at. And in this case, glucose is considered an effective osmol, meaning that it doesn't penetrate the membrane. And so the only thing that's going to move is water. Glucose is not going to be moving in and out because glucose requires a transporter, and we're just talking about diffusion or osmosis. So we're saying that 100 milliosmoles of glucose is inside, and then 200 is on outside. So we have more particles on what side?
Outside.
Right, the outside, because it's, as I said, 200 milliosmoles of glucose outside. So therefore, the water concentration, where there's greater number of solute, is going to be low. Water is going to be low. And we said that in the inside, it's going to be less less particles or less solutes of glucose, and therefore more water availability. And water travels from high to low, so therefore the water is going to travel from inside to the cell to the outside. And therefore cell will shrink. It's kind of a common concept that we apply in general. So does that make sense so far?
Mm-hmm.
All right. I don't know what that was, but okay. So here comes the main concept, and it's these graphs. They're known as the Darrow Yannet diagrams. But essentially, we can determine, based off of these diagrams, what's kind of going on in the body and possibly what pathologies are occurring or what physiologies are occurring. So what we need to first know or become familiar with is, so the y-axis here is representing the solute concentration. So solute or osmolality. So the height is the osmolality. And the x-axis is going to be the volume of either intracellular or extracellular volume. So the height is, again, osmolality, and the width, if you will be amount of extracellular, intracellular volume. And again, remember the 2/3 of the 60% is intracellular fluid, and then extracellular fluid is going to be the outside. And this is going to be extracellular fluid volume. This is going to be the normal. This, known as a y-axis, or this line determining height, is going to be the osmolality. And then on our left side is going to be the intracellular fluid volume. Okay, now to put this in words, extracellular volume. So this is going to represent net gain of fluid by the body, so we're saying that when there's a net gain of fluid or volume, it's going to enlarge, or the extracellular volume is going to enlarge. And if there's a net loss of body fluid, extracellular volume is going to decrease. In terms of concentration of solutes, this is going to be equivalent to the body osmolality. So body solutes, body osmolality. And in steady state, the intracellular concentration of water equals the extracellular. So if we're steady state, equilibrium, intracellular is equivalent to extracellular concentration of water. And the cell membrane is not a barrier for water. Right, because cell membrane is a barrier for solute or sodium. So keep that in mind. But right, it's not a barrier, meaning it's not preventing water from diffusing in and out. It's just sodium that is going to control. And so this is why intracellular and extracellular osmolarities are the same, because diffusion of water occurs freely, depending on concentrations. And then the intracellular volume, this varies within the effective osmolality of the extracellular compartment. So intracellular volume is determined by what's going on in the extracellular compartment. So if solutes and fluid enter and leave the extracellular compartment first, for example, if you were sweating or having diarrhea, solutes and fluids enter and leave first, is what it's saying. And that in the intracellular volume, so the first compartment affected is going to be extracellular, and then that will determine what happens intracellularly. So intracellular volume is only altered if extracellular osmolality changes. Does that make sense? So I guess to put that in perspective, again, if the extracellular osmolality increases, so number of solutes in the extracellular compartment increases, then the cells lose water and shrink. And if the extracellular osmolarity decreases, then cells are going to gain water and swell. Does that make sense?
Mm-hmm.
Alrighty. Okay. So, okay, so now here's a change. The dashed line is representing a different physiological state. And essentially, I just want to kind of get our minds thinking that what happened or what changes occurred. So the solid line, or the gray line that you see, is the control state, and the dash is what's changed. So there has occurred a decrease in the extracellular volume, a decrease in the osmolality, which is that height or the y-axis, and then a increase in the intracellular. Does that make sense?
Mm-hmm.
Okay. And then again, if extracellular osmolality increases, then water is going to get pulled out from the cell into the ECF, right? Because there's more osmoles, more circles, more particles on this side, meaning its ratio within this compartment to water is that there's less water and more solutes. And so to equilibrate that, water is going to move from the intracellular out into the extracellular to create a equilibrium. Okay. So the next concept I wanted to talk about is an integration of physiology that we know. So blood pressure is directly related to the extracellular volume. We always know as if there's an increase in volume, that means there's an increase in blood pressure. And if there's a decrease in volume, then generally it's going to be a decrease in blood pressure before other physiological changes happen to compensate for that. And two key hormones that cause regulation of volume is going to be our aldosterone and arginine vasopressin, aka antidiuretic hormone, aka ADP or arginine vasopressin. So just a brief review. Aldosterone, its main role is to increase sodium reabsorption in the principal cells of the kidney. So it's going to regulate extracellular volume. It also plays an important role in regulating plasma potassium and increases the secretion of potassium in principal cells, as we know. And the two primary factors that are going to stimulate cause for aldosterone release is going to be angiotensin II and plasma potassium. Antidiuretic hormone, its main role is to stimulate water reabsorption in the principal cells of the kidney at the V2 receptor. So this regulates extracellular osmolality. Arterioles and thus can serve as a hormonal regulator of vascular tone. So that's its compensation. And then the two primary regulators of ADH are plasma osmolality, which is directly related. So if there is an increase in the osmolality, that's going to increase ADH. And if there's a decrease in osmolality, it's going to decrease ADH. And then blood pressure and volume are inversely related. So if blood pressure increases, then ADH is going to decrease or not be released or not. If blood pressure or volume increases, we want to diurese. So yeah, right. So ADH is going to be decreased or inhibited. It's anti-diuresing. Versus if there's a decrease in blood pressure or volume, we are going to need ADH to not diurese any more volume in the body because we need to save as much as we can. Make sense? Okay. And then last regulator that we need to talk about is renin. So the main role is that renin catalyzes the conversion of angiotensinogen to angiotensin 1, which in turn is converted to angiotensin 2 by ACE. So the three prime regulators of renin are going to be perfusion pressure to the kidney. And this is an inverse relation. So when when perfusion pressure to the kidney is adequate or high, then it's going to inhibit renin release. Versus if the perfusion pressure to the kidney is low, so not enough blood flow, then it's going to stimulate release of renin. And we know that because then renin is going to cause RAS to occur and essentially cause vasoconstriction to bring up and allow for perfusion to occur, for perfusion of the kidney to occur or increase the blood pressure. The second regulator of renin is sympathetic stimulation to the kidney via the beta-1 receptor. So if beta-1 receptor senses stretch, Okay, never mind. I'm not going to talk about that, so I don't confuse myself. But sympathetic stimulation to the kidney is going to occur directly by beta-1 receptors, which is where renin is released. And then sodium delivery to the macula densa is also inversely related. So if sodium is high, then we know water follows sodium. So that's most likely meaning that we have an increased blood pressure. So it's going to inhibit the release of renin from further increase of blood pressure, because the RAS axis, if you will, causes release of aldosterone, and aldosterone is increasing blood pressure, and we don't want that because we already have increased blood pressure, most likely. However, if sodium is low, then most likely there's less water and blood pressure is low, so we need to stimulate renin to cause release of aldosterone and cause vasoconstriction and increase blood pressure. Okay. All right, so the main point is now determining if we were presented a Darrow Yannet diagram, what does it mean and what pathologies could it indicate? So here we're talking about loss of isotonic fluid. So this patient would show a loss of extracellular volume, as you see that the red line is impinging on the extracellular fluid space. So there is no change in the osmolarity, as you see. The line is still as it was, and there's also no change in the intracellular volume. And this, like I said, is an isotonic fluid loss, so there's equal loss of fluid and osmoles. And so what are possible causes of decreased extracellular fluid? We're just talking about, we said earlier in the presentation, the extracellular fluid volume is directly related to blood pressure. So if we have, sure,
blood loss,
but what are, right, exactly. So, yep, blood loss. So the patient could be hemorrhaging, they could be vomiting, diarrhea, urine loss. So anything that's essentially saying they've lost fluid from the body. And so now I want to throw in that integration of why I kind of reviewed the whole renin, aldosterone, and antidiuretic hormone and apply this to the situation. So what would our blood pressure be with that decrease in extracellular fluid?
Low.
Right, it's directly related. So if extracellular fluid volume has decreased, then that means our blood pressure is decreased because we've lost fluid. If we've lost fluid, then what is going to be the activity of the RAS?
Activated.
Increased blood pressure.
Sorry, I heard a little bit of talking. It's going to be increased because we need to bring up the blood pressure. We need to get aldosterone to increase and be released so that it can reabsorb the sodium, and it brings water along, and so that will increase our blood pressure. And then what would be the AVP or the antidiuretic hormone activity?
Increased.
Antidiuretic, right. It's going to prevent, it's anti-diuresing because we already have low blood pressure. So if antidiuretic hormone was not increased or doing its job of preventing diuresis, then we're going to lose water more, which is further going to decrease our blood pressure. Okay, so moving on. This plot here is representing a loss of hypotonic fluid. So this is showing loss of extracellular volume and loss of intracellular volume, and then there's a rise in the osmolality. And so this is going to represent a net loss of water. As we see on both sides, water was lost. And the ratio of water to osmoles is that there's more water loss than osmoles. Osmoles kind of just got smushed, and so they got increased. So what could be the possible scenarios of a patient here? It's a little bit harder or maybe less intuitive, but this patient would be essentially dehydrated, so they don't have an adequate volume in water intake, or they could be sweating, so maybe like a marathon runner, or they have hypotonic urine, and that could be indicating that they have diabetes insipidus. And I'll talk about that in just a second. But what would be the blood pressure of this patient here? Again, the extracellular volume is decreased, so blood pressure would be
Decreased.
right, because it's a direct relationship. And therefore, the RAS would be
increased.
And exactly, perfect. And then, so the pathological association here, if there were any to think about, would be that the hypotonic water loss is from urine resulting from diabetes insipidus. So that could be kind of your differential on this patient. Okay, so the next plot is representing a gain of hypertonic fluid. So this patient is showing a gain of the extracellular fluid volume, an increase in the osmolality, but a decrease in the intracellular fluid. So the osmolality shifted water out of the cell and into the extracellular fluid compartment. And so here there's a net gain of solute, so there's increase in osmoles, which is going to be greater than the increase in water. So what could be the possible causes of increased extracellular fluid volume?
Too much drinking of water?
Okay, yes, possibly. Or what could be causing fluid to move out into the extracellular space?
Less solute?
Cell death.
Okay. Yes, but the cell hasn't died yet, because then this red line would probably be like at the zero, because intracellular is inside the cell. So, but okay, you were kind of on the right track in terms of the solutes. We did say that, yeah, there
sodium?
is exactly
Hypertension.
Yep. Yeah. Exactly. Excessive salt intake or hypertension, like you said. They could be given a hypertonic saline solution, like if they were in the ICU, I guess. Hypertonic mannitol. I will explain that in a second, I think. And then initial effects of hyperglycemia, because not only does water follow sodium, but it also follows glucose. So the initial start of hyperglycemia patient could represent this whatever plot that'll look like this. So like I said, possible causes are ingestion of salt, hypertonic infusion of solutes that distribute extracellularly, so saline or mannitol, or a hypertonic infusion of colloids, so the colloids being dextrans, and dextrans doesn't really readily cross the capillary membrane, and remember the capillary membrane is in the extracellular fluid volume compartment, and so that's going to expand that compartment, the vascular compartment, so this area is just going to be overall enlarged. Okay, so what is the blood pressure of this patient going to be?
Increased.
Right, and what is RAS going to be? Exactly, because we already have increased blood pressure, we don't want to exacerbate that anymore. And what would be the ADH or ABP?
Well?
Yeah, exactly. It's going to increase, and I kind of had a hard time of coming to terms with this. But what you want to think about is what I said earlier, being that the osmolality line is really determined on whether ADH gets stimulated or not. So if there's an increase in the osmolality, like you see here, then that's going to cause the ADH to increase. Cool. And there really isn't a pathology that I came up with in the gain of hypertonic fluid. In this next plot, this is going to be gain of hypotonic fluid. And so here we have this patient with increased extracellular and increase of the intracellular volume space, and there's a decrease in the osmolality. So the fall of this osmolality caused a shift of water into the cell, which is why you see thus a net gain of water on the both sides of compartments, and there is more water than osmoles. So what could be the possible cause now? Yash, you said this a little bit earlier.
Drinking too much water.
Yeah, so primary polydipsia is going to be represented by the net gain of water, and then osmoles fall short. And then they could also be given a hypotonic fluid or saline solution. And so what would be the blood pressure of this patient? We have an increase in extracellular fluid volume. Exactly.
Low.
What would be RAS? Yep. And what would be the ADH-AGP? What is happening to the line of the osmolality here?
It's decreasing, but so increasing.
Yeah. No, it's a direct relationship. Mm-hmm. Yeah, it's a direct relationship. So if the osmolality decreases, the antidiuretic hormone, the ABP, decreases. And the pathological association here is that the patient could be having abnormal water retention. And so that would be syndrome of inappropriate ADH. SIADH would be what this patient could pathologically be looking at. Alrighty, getting to the end here. This plot is representing a gain of isotonic fluid. So this patient has an increase in that extracellular volume space, but no change in osmolality or the intracellular volume. So since the osmolality did not change, the volume is unaffected. And overall, there's a net gain of isotonic fluid. So there's equal increase of fluid and osmoles. So what would be the possible cause of isotonic fluid gain?
Saline infusion.
Exactly. Fluids such as saline. So infusion of solution, so saline, or colloids like dextrans, plasma with proteins. And so what would be the blood pressure of this patient?
Increased.
Exactly. And RAS would be?
Decreased.
Yep. And what is the ADH?
No change.
Decrease or no change. That's true and right. So, And okay, so the pathology in this patient could be that they have excess aldosterone. And as we know, aldosterone is a hormone that's going to cause a sodium retention by the kidney. So at first glance, we could think that there's excess sodium retention by aldosterone, and hence why that would be increasing concentration of sodium in the extracellular compartment. But this is rarely the case because water follows sodium. And so even though there's total body mass of sodium increases, its concentration doesn't. So I believe this could be essentially like Conn syndrome. So lots of aldosterone. Yeah, this would be like Conn's syndrome. So like an adrenal tumor. All right, and this is the last one. And this one is showing loss of hypertonic fluid. So this patient has a decrease in the extracellular fluid volume. Osmolality is decreased, and then there's an increase in the intracellular volume. So the rise in the intracellular volume is a result of decreased osmolality. So water shifted into the cell. And overall, this is a net loss of hypertonic fluid. So more osmoles are lost than fluid. And so, the only thing that you can really consider in that one is just a pathology, and that would be adrenal insufficiency. So a lack of mineralocorticoids like aldosterone. So there's excess loss of sodium. So our blood pressure is
decreased.
Yep, decreased, and RAS would be?
Why is the blood pressure increased here?
Oh, sorry, it's supposed to be decreased. My bad. Ignore the arrow. It's supposed to be decreased.
Okay, so then RAS would be decreased.
Yes. Oh gosh, all the arrows are wrong. Okay, ignore the arrows and
ADH would be down as well.
Okay, so ADH will be down, yes, because the osmolality is down. Okay, so we're going to lose all that. But yeah, osmolality is down, so ADH is down. Blood pressure is decreased, and therefore RAS is increased. Ignore all that. And then, again, the reiteration of the pathological association with adrenal insufficiency, lack of aldosterone. So that's all I got. And I know that I found this confusing, so I can just quickly go over that idea. Is that ADH? Again, remember that regulators of ADH are the plasma osmolality. So that y-axis line on the plot, it's directly related. So if there's an increase in osmolality, that's going to stimulate ADH, while if there's a decrease in osmolality, it's going to inhibit ADH. Cool. I don't have any questions because I thought my presentation was really long, and I couldn't find a good question.
All good.
But any questions or confusions or something I said wrong?
Nope. Good.